Good evening, everyone, and I hope you're having a wonderful, beautiful summer. I know I am. I'm here in gorgeous Wheeling, Illinois, northwest of Chicago, sitting along the beautiful long beaches here in the Gulf of Illinois. Oh, wait, there's no Gulf of Illinois and there's no beaches. But what the heck? Tonight, we're going to talk about total pediatric dentistry. My name is Mark Cannon. I'm a professor in the Department of Otolaryngology, Division of Dentistry at the Feinberg School of Medicine at Northwestern University. I'm also the research coordinator and director of the dental division at Ann and Robert H. Lurie Children's Hospital of Chicago, here in Chicago, Illinois. And I'm sorry, we do have good beaches around Lake Michigan. There you go. Disclosure and conflict of interest. As many of you know, I am a consultant for a number of companies. I have done so not for the money. I've done so more because I am just enthralled with what we have learned, with all the research and everything that's going on. And we'll talk about a lot of that tonight. I'm a very conflicted person. Everyone tells me that. My psychologist, my spouse. I know I am a conflicted person because who else loves their grandkids but loves to see them terrified on a ride? So who am I? Well, I mentioned I'm a professor, but I'm also a diplomat and fellow of the American Board of Pediatric Dentistry. I've been in practice in 3 locations, but in Long Grove for over 42 years. I'm now clinically retired, but I'm taking a very important position in academia. I'm a fellow Academy of Dental Materials, a master fellow, and on the executive board of AOSH, the American Academy for Oral Systemic Health. I am the current president of the board. And as you know, AOSH, the American Academy for Oral Systemic Health, were the leaders in trying to bring medicine and dentistry together. And who else should be president than someone who's actually part of a medical staff at a medical school, a very well-known, respected medical school. 5 kids and 5 grandkids. I'll show you some kids' pictures later. Share those with you. And I love cars. I do love beaches, live music, microbreweries. My biggest professional honor is to have been invited to the Nobel Forum in 2016 and to be part of the 2017 Nobel Assembly at the Karolinska Institute in Sweden. And in fact, here's actually my copy of my badge. You can see at the Nobel Assembly. I want to show you just as Mark Cannon, USA, and there's something very, very important about that. You don't see DDS, you don't see DMD, you don't see MD, you don't see PhD. See people who are really part of that great quest of Alfred Nobel. Alfred Nobel was a chemical engineer. He didn't care what degree you had. It's what you did. And what we do is like, for a little Lukey here. Luke is one of my grandsons. That's what we do, especially in total pediatric dentistry. We care about everything. Airway, prevention is king, always. But how that 2017 Nobel Assembly, we talked about the gateway microbiomes and evolutionary oral medicine and how we have an oral, nasal, vaginal, and placental microbiome that are gateway microbiomes there to defend the host. Barrier microbiomes exist too, like on the skin. But the whole idea about evolutionary oral medicine and about the oral gateway microbiome is so important, as they thought in 2017 at the Nobel Assembly, because nothing in biology makes sense except in the light of evolution. We've all heard this, right? But nothing in dentistry makes sense except in the light of evolution either. When you look at the skulls, you can see the evolving face, the evolving craniofacial respiratory complex of who we are the kings of. So the oral gateway microbiome is so important because if you have a dysbiotic oral microbiome, according to Inger Olsen and many other very excellent researchers, you will have eventually a dysbiotic gut microbiome. And people at the Karolinska Institute and from all over the world, there's people from all over the world. To see all the names listed here. Like I said, you don't see any MDs, PhDs, didn't matter. You could have had your bachelor's in microbiology, but if you discover something important, you're going to be there, right? They didn't care about titles. So everything, all this stuff affects everything epigenetically, including cancer. And it's so important for us to realize these oral and nasal gateway microbiomes. We just completed the first deep sequencing whole genome of the nasal microbiome, coming up with over 2,500 species. We're not going to talk about that tonight, but those important taxa, I should say, really control everything about the nose, how swollen it is, how thick the mucus is, what's in the mucus, how well it filters, how much nitric oxide production you have, everything. How well you can breathe through your nose dictates whether or not you can also have obstructive sleep apnea. If you block the nose, you will have it become a mouth breather, and then you'll get large tonsils and adenoids and other issues. And that leads to more oral dysbiosis. But oral dysbiosis, we already mentioned, leads to gut dysbiosis. And when you get gut dysbiosis, everything goes downhill. Now, you've all seen these type of slides many, many times. No one is surprised to hear a gut dysbiosis is associated with depression, anxiety, pain, stress, everything. Hypothyroidism, right down the list. Of course, obesity and type 2 diabetes, all that. We all that, and cardiovascular disease. And this is missing a bunch of important things like cancer. Cancer isn't showing here, which is really shocking for what we know today. So at AOSH, we talk about all this stuff all the time. American Academy for Oral and Systemic Health, we have a lot of excellent, wonderful, state-of-the-art lecturers who are the top names in science, all combining everything they know about their field with an oral twist. So you know exactly how dentistry fits in. But I do know one thing: you are the most important healthcare professional for everyone, especially kids. And the most important person in your office may very well be the dental hygienist, because a dental hygienist is the one who has the time and should have the education to share all this knowledge with the patient. A properly educated patient becomes a very loyal patient who shows for all their appointments. You don't have the no-shows. You don't have all the people showing up really late. They value your time. They want to come in and learn more. This is one of the biggest problems DSOs have right now. They're trying to cut down hygiene appointments and time. Huge mistake. You lose the patient long term. They'll want to go to someone who will spend the time to tell them about all these new and exciting things. And we're not making any of this up. If you go through the literature, you'll find all these articles like this classic in JAMA from April of 2019. They looked at kids who had oral infections that had been followed for over 755 of them for over 27 years, up to 27 years. And then they looked at all the cardiovascular risk factors by like doing CIMTs, the carotid intima media thickness ultrasounds. They found the kids who had all the problems with the oral infections were the first to show the signs of cardiovascular disease. Now, since then, there's been a number of articles. There's that 145-year follow-up out of Norway, where they followed people for 45 years, and all the people had the dental problems, had everything down the road. Now we know we can tell our patients how important it is for them to take care of their mouth, of their oral health. And this is some stuff I share here with that Tom Neighbors talks about all the time, Dr. Tom Neighbors. About 1 millimeter alveolar bone loss, there's a 14% increased risk of all-cause mortality. I love this one. If you have greater than 10% periodontal pocket depths or greater than 5 millimeters, they have a 70% greater chance of dying sooner. Tooth loss is associated with a 59% increased mortality. All these incredible studies have come out. Tooth loss and other problems are associated with 27% decrease in lifespan. If you tell this to patients, and this begins in childhood. This begins in childhood. In fact, it begins before childhood, which we're going to talk about. Then you have patients who understand how important it is in dentistry and for them to have a good dental home in their life. And of course, the biggest news in cancer, the last 3 years, I've been doing a lot of cancer research with humanized mice. We're finding incredible stuff. But the Deborah Nejman study that came out in May of 2020 in Science, when they reported that they had looked at over 1,500 human tumors representing 7 different types, big number of authors, as you see, about 60 authors altogether. They found specific, look at that, tumor type specific intracellular bacteria. Now, this was first noted back in 1920, but it took microbiologists 100 years to convince medicine that there was a very strong association between specific intracellular bacteria. Now we also know specific intracellular fungi and many of the different cancer types. In fact, not only tells you what type of cancer, but your survivability, how well you'll respond to treatment. That's why the FDA has approved tests like this, the Cancer Detect Oral and Throat from Viome. And next week, I have on one of my fireside chats through AOSH, Guru Manavar talking about Viome's newest total health test, which tells everything about the health of the patient through samples of their saliva. Is brand new and just approved by the FDA. And of course, in Science, a couple months ago, they came out saying if microbes are found in tumor and that promote cancer, why don't we just kill the bacteria? Well, actually, they're way behind. The study started in that about 3 years ago, and they're very interesting. The success rates when utilizing certain antimicrobials really go up. On the other hand, if you've had antibiotics before they start treatment for cancer, your success rate, your survivability drops unbelievably. If you look at the research coming on the National Health Service out of the UK. So now we know that we have to be extremely careful with antibiotics for everyone. I mentioned things can start before. When you talk about total pediatric dentistry, you're talking about taking care of the mothers. And in my long lectures, we talk a lot about probiotic supplementation, prebiotic supplementation for anyone who is pregnant. Incredible research that's been published by like Kirsty Argard from Baylor. She's head of maternal fetal health at Baylor on the use of just a xylitol gum on reducing adverse pregnancy outcomes with a group of over 8,000 women. I mean, really incredible research. But this one's on snoring, just checking for snoring. I will tell you this right now. All pregnant women should be checked for snoring and obstructive sleep apnea. Just checking for snoring alone can be very important. In fact, chronic snorers are independently associated with gestational diabetes. Both pregnancy onset and chronic snorers are independently associated with placental adhesion. Pregnancy onset snorers were at higher risk for cesarean delivery and having macrosomia, large for gestational age infants, and being overweight or obese before pregnancy plays an important role in actually mediating the snoring and adverse pregnancy outcomes. Obviously, if you have additional weight, that can increase snoring. So all this is important. But the funny thing about pregnancy onset snoring and pregnancy onset obstructive sleep apnea, it can be so easily treated during the pregnancy. It's usually only for a trimester or two, and you can be treating that with a simple oral appliance. Every dentist should be doing this. We've known about this for over 7 years now. And another grandson. This is the newest addition to the family. This is Isaiah. As you can tell, he's a very new baby. But this is very important because having a healthy baby and a healthy baby, he's a happy, 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 healthy baby, can be related to the health of the mother before she even becomes pregnant. And this is why it's so important, because making him healthy now will make him healthy strongly. Very strong indication for the rest of his life. As I say, the first 1,000 days are the most important, right? Everyone knows that. So they can reproduce what fetal hypoxia is like in animal models, like with rats. Obviously, you can never do a human study like this, a clinical trial, but they cause hypoxia on pregnant rats, and they find a significant change in the transcriptomes in the brains of these animals exposed to intermittent hypoxia. Of course, when you're talking about the transcriptomes, you're talking about the RNA and the expression of the RNA. So it changes a lot of the metabolomics that are involved, all the metabolites as an end result. and it causes ischemia that can affect later on development. And this is what I think has happened with my practice. I was seeing so many kids with developmental delay, and there would be no explanation in the chart, be it no explanation from the hospital. I'd ask mom, and she would say, well, he has developmental delay. Was there any specific reason listed? No. I wonder if the mom hadn't had obstructive sleep apnea, because it does cause it in animals. And the other interesting thing, some great research by Takashi Ono, is that if you do intermittent hypoxia on a pregnant rat, it changes how the geniohyoid muscle is developed and how the mandible grows. So you end up having an infant then with a retruded lower mandible. Well, what does that do to the infant? It makes them far more likely to have feeding problems and also far more likely to have sleep apnea issues down the road too, or even as an infant. So we all know how important that is for kids. We know from the great work by Karen Bonneck, and it was published again, this is like 7 years ago, so I think everyone's had time to read this, is that the prevalence of short sleep duration, behavioral sleep problems, and sleep disorder breathing amongst children aged 3 to 5 is between 20 to 50%. It is astonishing how many kids I would see in my pediatric practice with airway issues and how much work we could do with airway. Again, astonishing is sometimes we just use an over-the-counter xylitol nasal spray, and that would fix the issue. And we would do a lot of sleep studies. And of course, it's not my subject tonight to talk about sleep in general, but it's so important that kids get a good night's sleep because it affects their learning, it affects how well they do in school, it affects how they behave. The behavioral is such an important component because if they get a reputation early on in life as being a troublemaker, it can follow them for a long time, and they may set their own standards much lower. And of course, then we have biological dental materials. And we all know a whole list of them, from MTA, the grandfather of all, to biodenting, to Limelight, Neo MTA, Theracal LC, Therasam, a few other Therabase. I don't have a lot of time, obviously. I'd love to spend hours on all this, or Infinix, or even Omnichroma, because really, structural color is a biological effect too. But we don't really have time to cover all of it. I'll go over what I am most familiar with and what I think is so vitally important. One is to understand biological materials typically use a calcium, and one of the most utilized calcium is dicalcium, tricalcium silicate. And that really basically comes from what that person is walking on. It comes from limestone and diatomaceous earth. And you use it in everything. You see concrete being poured everywhere right now for foundation, buildings, new roads, everywhere. It's so safe, it can be used as an anti-caking agent. So it's really ideal, approved as a safe food additive, a large number of products. But it all really came from Portland cement, the Loma Linda patent from 1993, 1995. On the application, you see they utilize a Portland cement with tricalcium silicate, dicalcium silicate, tricalcium aluminate, and the aluminum wasn't such a great idea, and the tetracalcium aluminum ferrite. So as you know, all aluminum stuff has been removed. But this is what it started off at. It was just some Colton fast set Portland cement from the California Portland Cement Company, a type 1 cement. Very, very common. Well, I've been working in biological materials since 1978. I actually started working in the microbiome back in 1975. So I've been around working on this stuff for a long time for a number of companies. And I really felt that we always had to get to a point that we had things that were more natural, that would do what the body needed. So we would have to have a base, a liner that would be alkaline and give off calcium. That's what we need, the ability to sustain the alkalinity, but not crumble. One of the problems we ran into at the beginning is with composites. The composites could flex, they would shrink on polymerization. You might have a little micro leakage, and the dical would wash out. In the old days, doing a gold crown or doing a gold onlay and sealing it with a zinc phosphate cement, you didn't have that problem. Even with amalgam would tend to expand, right, with moisture. and it would actually try to fill in all the gaps. It didn't shrink like composite. And so the issue was to try to get a very kind resin that would allow to be hydrophilic, that would allow the calcium to come out, the calcium ions and the hydroxyl ions to come out. And of course, when you look at things like the MSDS, they don't really tell you the whole story. They only, and this is very important, they only tell you what is in it that is equivalent. So they can say Portland cement type 3, because that's actually what we started the research with, because type 3 is much better than type 1. And of course, it says polyethylene glycol dimethacrylate. That's not correct, but it's similar to it. And of course, barium zirconate, as the radiopacity. And don't let anyone ever tell you that resins are really, really inherently bad. Of course not. You have all these contact lenses. Contact lenses go back to the 1930s with polymethacrylates. Right now, of course, are polyhemas that are being utilized. You can put a contact lens on your eyeball and keep it on there for a long, long time. I used to wear contacts, but then I had LASIK, and then later on, as you get old, what do you get? Cataract surgery. Yeah, resins are evil, I say. But we do 4 million cataract surgeries a year in the United States alone. And they actually make a little hole and they shove this plastic lens, which again is a polymer, into your underneath your cornea. And you get this as your substitute lens. It can be a very easy procedure. It can be not so easy. Some people are well sedated and they just kind of flow through it like no big deal. I cannot have fentanyl, and they typically use fentanyl as sedation. So of course, when I go on a respiratory rest. But when I had my procedure, of course, they had to just do it with a local anesthetic. So it's less fun that way by far, trust me. But they can be very biocompatible, right? Obviously, you put 4 million a year alone in the United States. That'd be 8 million lenses into people's eyes, and they have no problem with it. And they're polymers. So this is work that was done by Professor Dr. Carlos Alberto de Souza Costa, and at Araraquara University, and on the cytotoxic effect of a light cure pulp capping material. This came out, quite some time ago, like 10 years ago. And he used an immortalized odontoblastic cell line. And he would take the diluent from 4 different groups, the Theracal LC group, which is a light cured tricalcium dicalcium silicate, Ultra Blend Plus, which is a light cured calcium hydroxide product, Vitribond, which is a resin modified glass ionomer, and of course the media, which is the famous Dobecco's modified EDOL media. And that's the positive, because that's what the cells grow. And he used these immortalized cell lines. And then they would go and do the MTT assay. As you know, the MTT assay checks for vitality. And it looks at the metabolic activity, which is a good check of the vitality. In fact, it's a colorimetric one. You can actually see the color changes in their vital cells. It kind of turns all purple from it. And then they looked at the succinate dehydrogenate activity. And basically, of all 3 materials, Theracal decreased the cell metabolic activity the least and had the least effect on cell mortality, more on vitality, least effect on cell vitality. And same thing on total protein expression. Theracal was the most kind. And of course, this is again independent research done by a university, just looking at the various types of effects, cytotoxicity, that you would have using immortalized cell lines, which is the first step, boys. And then you do animal studies. And as you know, I did do animal studies on Theracal LC too, showing it to be very biocompatible, much more than the other products in the study. So what happens in private practice? Well, this is actually a patient I saw who came in as a new patient, always having a teenager, always having pain in this tooth that had just been restored. They said a few months before, but could have been a year. It could have been 2 years, but they always say, he just had that done. And it's been really bothering him and having spontaneous pain, couldn't eat on it. The dentist, they called him, he said there was nothing wrong. And of course, the first thing you notice is the occlusion, right? I mean, obviously, when I numbed him up and put the rubber dam on, he'd never seen rubber dam before. It kind of looked like someone just squirted the amalgam in, rubbed it with their finger, and had the person bite down to put in the occlusion. That is like the opposing cusp in it. And that's why I just had to take pictures of this, right? And if you look at the margins, you can see how it's really leaking bad. This is a young patient. This isn't someone who's 40 or 50 or 60. This is someone who's like, I don't know, like 12, 13, something like that. And so I removed the amalgam and it just flew out because it was never properly condensed. So I'm not blaming the amalgam. It wasn't placed right. Underneath, there was DiCal, super soft, because it had leaked significantly, and that leakage allowed the DiCal to just completely dissolve. And of course, it was that void and all that softened DiCal that was causing the pain. So I took away all the soft stuff because, of course, the dentin was heavily decaying because of the fact you can't brush something underneath a restoration. That was kind of hard, that stain. I kind of left that just so you can see the pattern of the leakage that came around the margins and wrapped around the DiCal that was dissolving, that would leak underneath to make decay. And so why do we have these situations? Well, I have to tell you, you have to look at the literature. This was done at the Aristotle School of Dentistry at the Aristotle University in Greece. And they use some nice state-of-the-art type materials for a dental school, right? I mean, it's like a dental school. DiCal, Vitribond, Clearfill Triespon, and Clearfill Magistry. And of course, Carrari makes good products. You know, they're a good company, Carrari. And they had, 6 groups that they looked at, but 5 out of the 6 had problems. The only one that didn't was group number 6, where they would have dentin, bonding agent, Vitribond, more bonding agent, and then Clearfill Majesty, the composite. And this is easily understood because Vitribond is, again, a resin modified glass ionomer, and so it has a lot of moisture. It has water in it. And composite is very hydrophobic, right? So you can't put composite directly on top of Vitribond because it's like putting oil-based paint on top of wet wood. It just doesn't work good. I mean, it may look like it's okay, but really isn't. So you need to have bonding agent there, but to have the Vitribond bond well to the dentin, you also need bonding agent. But then if you have good bonding agent on the top of the Vitribond and the bottom of the Vitribond has no purpose because the fluoride release is prevented. So you're like, oops, there's a problem, because you might as well have just done Clearfill Triespon on the dentin and then just built up the Clearfill Majesty in layers to have the same effect. So they actually looked at the void formation that they would see, and they would see a good amount of void formation that would form between the DiCal and the Clearfill, between the DiCal and the Vitribond, between the Vitribond and here, because that's the weakest link, and also here between the Vitribond and the Clearfill Majesty, because again, this is wet, this is hydrophobic, and so this would be the weakest link here too. And so at these really weak links, they would have these big gaps, really big gaps. And big gaps, that's not a good idea at all. So basically, there's no bond between DiCal and Vitribond at all. And between dentin and DiCal, there's no bond. Now, you could get by with it, like I mentioned before, with a casting, okay, because it goes right on top of it, or amalgam that you're packing down because you're packing down the calcium hydroxide at the same time. But when you do a composite and you cure the composite, it's going to shrink. It's going to pull the DiCal away from the dentin. And the shrinking is enough to actually pull the resin modified glass ionomer off too. Resin modified glass ionomers like Vitribond only have a bond strength to dentin of about 7 to 9 megapascals, and the polymerization shrinkage can be 12. So if you have a deep preparation, you're going to end up with a gap that's going to pull away. And you've seen this 1,000 times on a lot of different diagrams, I know. where you have the composite shrinking. And if you have like DiCal, it's going to pull completely away. It'll suck the DiCal completely off the dentin. And if you have a glass ionomer, it's going to pull the glass ionomer right off the dentin too, because there's not enough bond strength between the dentin and those materials. And then you're going to have fracture along any areas along the margin. Now, this is actually one of my own composites. As you know, I do a lot of research where I've retrieved over 1,300 primary molars that have been restored and sent them off to multiple institutions from Loma Linda to University of Tennessee, Memphis, to other places, Birmingham, and so on. And yeah, also NYU. Where they could use them for doing various studies with either TM or SEM, and you can see all the little crazy important details. Like here, I had a little flash, and you see the composite cracked right along the margin of it, which is to be expected, actually. So here what I do is, because a patient had sensitivity, I want to have something that's alkaline. I want to have something that's calcium releasing. I want to have something that will be dual cured, because he already went through a problem with a poorly placed restoration. I want to make sure this is dual cured. I build it up thick. So I place a dual cure material, Theracal PT, in there, and I placed it and cured it. And then this will have all these good positive purposes. You use it for pulpotomy, pulp capping, base liner. Usually I use it mostly for base and liner. As a base, a dentin replacement is really ideal. You could use it as a temporary filling, but people think it's too expensive. A lot of clinicians say that. But for therapeutic remineralization, it would be good. You have a good amount of calcium releasing alkalinity. Then I just restored it. I use Activa from Pulptin as a restorative material. Here you can see the occlusion has been adjusted. It's just slightly in contact. You see a little bleeding. That's from removing the rubber dam, flossing to make sure there's no bonding agent in between, and also from using single tooth anesthesia. I love single tooth anesthesia. I think it's fantastic in pediatric dentistry. I do put all the anatomy back in too, by the way. I just think single tooth anesthesia, or it can numb up someone really well, and only their tooth is numb. They can go on and go back to school. They can wrestle with a wrestling team. They can play on the trombone and band, whatever they need to do. And this gets out. I mean, young people like to tell other people about good experiences. It really does get out. You get a lot of patients coming in who have had bad experiences. Now you're going to give them a really good experience. Now, the FDA has always said you cannot have active calcium fluoride in a water-based toothpaste. And to get around that, MI Paste Plus, GC had to do a lot of work to keep it so that the calcium and fluoride would not unite. And they developed, they use casein phosphopeptide, which keeps both the fluoride and calcium active. So it's always a pet peeve of mine when I see people actually placing DiCal, then putting on top of it Vitribond, because the calcium from the DiCal should be inactivated by the Vitribond, and the same thing with Theracal. So it's a pet peeve of mine, because calcium fluoride is insoluble. There's the structure of calcium fluoride. It's an insoluble structure. Now you can say, well, what? Calcium fluoride's insoluble? Yeah, let's just look this up real quick. Let's look up in the American Chemical Society, insoluble in water. And I say practically, but really, I mean, it's almost no solubility at all, right? It's that way in all the textbooks. It's that way in Wikipedia, the FDA. Everyone says calcium fluoride is a set crystal. To break it apart takes a ton of energy. It's even compressed down to make camera lenses. But somehow at dental meetings, they talk about calcium fluoride like it's really something good. And I'm really surprised, because this is basic freshman inorganic chemistry. In fact, I'll show you something out of a high school textbook. But they talk about calcium fluoride being a reservoir in the saliva to be available for remineralization of teeth. But what is actually in the saliva is phosphate-containing calcium fluoride, which is formed at the expense of enamel hydroxyapatite and fluorapatite. So last, December, November, I was at an international, international meeting on prevention of dental caries, and it's supposed to be like leading experts. You'd be surprised of some of the really inaccurate things I heard from, quote, leading experts from dentistry, where I just wanted to say, hey, can I play a movie that they show in high school chemistry for you guys? Right here, there's a little video we're going to show here. Is it soluble or not? Calcium fluoride is soluble or insoluble. So you go and you look it up on a table. Yep, positive ions there. Answer is right here. Yep. Now you see right there, it's fluoride is insoluble. It won't dissolve, so it doesn't really do anything for you. So there we go. The solubility doesn't really exist. I mean, it's practically insoluble. So anyway, we decided we had to do a study on this just to demonstrate to everybody. And so we made samples with utilizing Vitribon, Theracal LC, and with Reveal, which is bulk fill from Visco. Wanted to see how much calcium you get out, what the strains are. And I presented this at the AADR meeting, the American Academy for Dental Research. And so for the calcium release, we had these 20 millimeter by 1 millimeter samples to just measure the calcium coming out 1 day, 3 days, and 7 days. And for shear bond strength, we have these other different size samples, 6 millimeters by 3 millimeters. And then we would soak them for 24 hours in deionized water at 37 degrees Celsius, and we break them on the Instron. And so in a nutshell on this, you can look at column 1 there, where you see the Theracal all bond universal and Reveal bulk, and you see the calcium release at 1 day. It's pretty darn good. It is running at about 208 parts per million, 208.6 parts per million. But if you just put in the Vitribon, it drops down to 143. And you see it really drops down when you just have Theracal and Vitribon. And so it is incredible, the drop in strength and the drop in calcium. So what happens is, of course, the calcium combines with the fluoride to make something that's insoluble. So you can't measure either the fluoride or the calcium. And other people have done this too. So it's just simply not a good idea. Whether it's with Dical or Theracal, don't put RMGI on top. Another little test you could do at home is just look at the acidity of things. We buy yourself some pH paper at Amazon for, I think it's around $5. And look at your etch. This is a really good etch. It's 32% with BAC, was a benzalkonium chloride etch. And you just check the acidity of that with a pH paper, and you're looking and goes, yeah, it's around it. It looks like about 1 to 2. It's supposed to be. It's actually 1.8, I think, 1.7 pH, 1.7 for that 32% phosphoric acid. And then you can look at a baseliner here from Pulp Dent. You look at the pH of that. You go like, wow, that is around 3. Well, that's not alkaline. That's really acidic. So that is really more like a glass ionomer. In fact, if you go ahead and do Fuji 2LC, you end up with the same pH, around 3 to 4, more toward 3, probably around 3.4 is what Fuji 2LC is in the literature. So that's acidic. That does not encourage remineralization. That doesn't encourage more reparative odontoblastic formation. It just doesn't encourage that. And then let's look at calcium LC too for calcium release. Now, this got very important to me because having been a Theracal user, all of a sudden our office was being told that we had to start buying calcium because it's the same product. I go, no, it's not. It's not at all the same product, completely different. Theracal LC is a tricalcium dicalcium silica based on a light cured MTA formulation with hydrophilic resin base. Calcimol is a urethane dimethacrylate that's hydrophobic with calcium hydroxide in it. In fact, when it was studied, it turns out that you have over 13 times the calcium release with Theracal LC than you do the calcium LC. And look at the pH, barely around 8. That's not good. And when you start off at that, it's going to be neutral in no time. So when you compare Theracal LC to calcium LC, you have to say, what is your dream car? And you can just say, hey, is it that car or is it this car? Yeah, I think you guys all want to have an AMC hatchback, don't you? Yeah, that's the dream car to have right there. So the funny thing is that the calcium is actually more expensive. So basically, because of its unique formulation that very few people have had any capability to copy, they have certainly tried. I would tell you personally that every company has tried to copy this, and a lot of them have contacted me saying, how come we can't get to work? And it's because you have to have the right proprietary resin matrix to work with it. And so you can see here again, the pH on that is, if you look real careful, the pH is around 11. In fact, it's close to 12. See, it's kind of in between 11 and 12. So that is alkaline. It's kind of like comparing apples to oranges, or I like to say ales to lagers, pilsners to stouts. I mean, it's completely different. So this is a picture someone took, a friend of me lecturing at LSU, and I was lecturing on rare diseases, and someone in the audience said, well, this isn't about rare disease, but we all noticed that you developed Theracal. I said, well, yeah, I worked on it, and I'm on the patent application. And they said, well, we can't use it. I go, you can't use it. Why? Well, because it has acidic monomers. I said, well, what's the pH of Theracal? They go, we don't know. I said, it's around 11. And go, what do you use instead? They go, Vitribon. What's the pH of that? They go, we don't know. I said, it's like 3.6. So again, it's apples and oranges, but you have to remember that sometimes students are being told things by faculty, or being told things that are coming out of people who are in sales and all that. Another pet peeve was that John Burgess had asked me about this at down in Birmingham, UAB, about how does it fail. There's a mush zone between Dical and Vitribon that everyone has talked about and lectured about. So if you see the Dical go down a little bit, you see the little mush zone, then you see the gap. And he says, Mark, take a look at it, because the mush zone is not in Vitribon, which I thought it had been in. I thought the Dical alkalinity prevented the Vitribon from doing its acid-base conversion. He says, no, it's actually in the Dical. And sure enough, we took a look at the gap is on the Vitribon side, but the mush zone is all in the Dical. It's all super soft. And then you have that big gap, and you have zero bond strength. We duplicated everyone else's research, zero bond strength between the Vitribon. If you just go to Dical itself to composite, you have a very low bond strength, virtually non-existent, but there is a little. And when you use adhesive, there is anyway. When you cure the composite, what happens is the Dical gets pulled apart, because the Dical will stick to the composite because of the adhesive, but then the Dical just crumbles as the composite shrinks. But see, if you go ahead and use Theracal, and then you do an adhesive and then a composite, then you have something extremely strong. The Theracal will stick to the dentin, and you'll have a strong bond between the Theracal, adhesive, and composite. Very strong. And this was presented at the Academy of Dental Materials. And this was, gee whiz, now 8 years ago. Seems like just yesterday. And the title of that meeting was Emerging Materials and Declining Dogmas. What a great title for a meeting. And then, of course, we have the great research by Joseph Camilleri which is published in Dental Materials Journal. She's commented that, and I met her at the meeting in Vancouver and complimented her on this work. And she's commented saying, well, dentists tend to put things on top of each other without actually understanding if those materials actually work together. So she did this great study showing how calcium hydroxide will work okay on top of MTA. Another thing that works well is calcium sulfate. So if you use like MTA, you can cover it well with like Tempon. And Tempon, I'm not sorry, not Tempon, but Tempit from Centrix will actually do well on top of MTA. But you don't want to put glass ionomer on top of MTA, and that's what my program was teaching. They're putting MTA in all their pulpotomized teeth and then putting glass ionomer on top. I go, no, you can't do that. That does not work well. And they were so surprised. And the same thing with IRM, because we had some attendings placing IRM on top. And Josette, these are all in quotes. This is taken verbatim from Dental Materials. MTA reacts to a lot of materials, zinc oxide, eugenol, like IRM materials, and it should be avoided in the presence of MTA. Zinc causes retardation of cement hydration with increased porosity, and glass ionomer cements absorb the water hydration from the MTA, also resulting in increased porosity, incomplete hydration of the MTA. And that's something you don't want, because then the MTA has to keep trying to pull fluid out of the pulp itself. Well, there ain't no such thing as a free lunch. We all know that. So you have to balance everything. You have to balance the bioactivity versus the stability, resorbability versus dissolvability, and calcium release versus mechanical strength. And so I think with the formulation with Theracal LC, we had a success. Same thing with Therasem, Therabase. And the clinical studies, like out of Michigan, you see that. This is all published stuff. This is 2018, published 5 years ago. 60 patients, each material, 69 teeth using calcium hydroxide products. The other group was with 79 teeth using Theracal. And with the direct pulping, the success rate was for Dical 50%, and for Theracal was 69%. Slightly higher indirect pulp capping success rate with calcium hydroxide than from Theracal, but definitely Theracal was as good, if not better, definitely for direct pulp capping than Dical. And of course, published in Dental Materials was this study that came out of Italy, and they looked at this light-cured MTA-like product, which was actually Theracal, and they had 3 groups. Group 1 just being an adhesive group, Group 2 being a glass ionomer group, and Group 3 being the Theracal group, and success rates at 2 years, vitality 83.3% with the adhesive group, Group 2 66.6%, with the glass ionomer, and in Group 3, success for vitality, it was 93.3%. So they said, hey, this is better. And that's what this result was shown to be in the Journal of Clinical Pediatric Dentistry. Again, indirect pulp caps, this was 24 months, 2 years, 54 teeth. Overall success rate of 100% in Theracal, 94.44% with biodenting, and 77.78% in Dical. So Theracal was significantly better in this randomized clinical trial. And you have to be really careful because people misunderstand the literature. This came out on cytocompatibility, antibacterial properties, capping materials. Okay, and these people are strongly associated with Calcimo LC. And they published this, not in a great journal, not at all. It's one of those many journals you find out there, just people try to just things published. But they looked at Calcimo LC and say, hey, look, it get a good job at not inhibiting, because the halo inhibition is on the left, so you want to have the biggest halo of inhibition possible, right? So Angelus, which is an MTA, had a big halo of inhibition. Hydrogen peroxide had a big halo of inhibition, inhibiting all the streps. But Angelus inhibited mostly strep mutans, a little tiny bit strep salivarius, almost none strep sanguis. You know what? Theracal was the same way, because that's what you want. You want to inhibit strep mutans. Strep salivarius is a probiotic that inhibits strep pyogenes. You never want to inhibit strep salivarius. Strep salivarius actually inhibits a lot of the periodontal pathogens too. The strep sanguis is one of the most protective ones at preventing early childhood caries in young kids. So they actually had the worst results possible with calcium LC, but they published it like it was great. I guess they they really wanted to make sure that no one understood microbiology, what was good bacteria, what was bad bacteria. But clinically, this is what I always ran into in private practice. I always had these kids referred that no one else wanted to see. A lot of times I got kids referred that were referred from other pediatric dental offices, and only wants natural products. This tooth will need to have a pulpotomy, does not want a crown. That's fine. I only use natural products. I don't use anything that's supernatural at all, right? The supernatural really bothers me, so I still have nightmares from those twins from The Shining. And besides, everything is dose related. I mean, this is a perfect poster, I think, for dental offices, that a lot of things in nature contain things that are not the best. And so, hey, we always have to go, it's dose related. Everything is dose related. And both those twins came back, after COVID, and they took all the toilet paper from all the stores. So here, of course, I knew I was going to do a pulpotomy. I knew I was going to do a composite. So here we go. Isolation, rubber dam, anesthesia was probably the single tooth anesthesia. Remove the pulp, extirpate it. I use ferric sulfate for hemostasis. Hemostasis is essential. Then afterwards, I place in sodium hypochlorite. That's very important to disinfect, to clean away the clot, all the extra clot debris, and remove all the pulpal tags. That's very important. Some people used to skip that. I use a medical grade sodium hypochlorite. And then you remove any excess hypochlorite, but you have to make sure your water is clean, because if you're using contaminated water, you're recontaminating the tooth at this point. You'll be better off not rinsing away the hypochlorite than use contaminated water. There you see what it should look like. That's hemostasis. All pulp contents have been removed. And this is essential for pulp therapy success. Look at the pink pulp. It's not bleeding. When people put Theracal in on, like Theracal PT, and a bloody pulp and the Theracal turns pink, success rate will be much lower. Do it correctly, success rate will be much higher. That's how it should look. You do that with a laser too. That's Theracal PT being placed in. Very biologically kind. You light cure it. You'll get the calcium ions, hydroxyl ions from that. Light cure it, but it'll continue to cure because it is a dual cure. And then you can etch it for 30 seconds. Rinse away the etchant, apply your bonding agent. I'm a big All-Bond Universal fan. I can tell you so many stories about All-Bond Universal, how we can have an associate come work for us. They move to another state, go to another office, and then all of a sudden they say, nothing's working. I never had a composite ever fail, and nothing ever failed. I'll ask them, what bonding agent are you using? And it'll be one of those really bad ones on the market. And bonding agents vary a lot. And people don't realize it, because a lot of companies will produce research in their in-house that will show their material to be fairly decent. But when you look at the independent research, you find that some are not good materials. So you can see we got no bleeding, the Theracal PT's in, I've got etch, I've got bonding material in. Now I can just build it up with a bulk fill composite. This is the dual cure bulk fill composite that's going in, and this is probably Activa from Pulp Dent being injected in. It's dual cure. Build it up, light cure. Before you do that, you want to make sure there are no voids. Make sure you use your Explorer. People get voids all the time with injectables. They leave in a void and they don't see it until they take a bite wing x-ray a year later. And sometimes those voids there's no consequences from them. They're not really an issue, but they could become an issue. It could lead to weakness of the composite or maybe micro leakage, depending on where they're at. So here we removed the matrix and the wedge. You note the gross anatomy has been placed already, and then you polish it. And then this is actually at a post-operative visit, like a recare visit. And I just shot a quick picture of it at that time. And of course, there was no issues whatsoever, no sensitivity or no problems. And the parent was extremely pleased. In fact, she commented, couldn't even tell anything had ever been done. Some other teeth, though, just showing the same thing. Using sectional matrices, you get those nice contours. On the bottom, you can see the monoblock design that we'd have when you do like TheraCal PT, then go directly to a composite. They're very strong and very durable. And you can do crowns. This is a case where the parents weren't concerned about having a crown done. So you can do a MO composite, large caries, big buccal, large caries, and the first primary molar. And again, I use a sectional matrix. This is from Garrison, and the wedge is from Garrison. Then you placing your TheraCal PT, make sure you get hemostasis in the pulp and the first molar. Then you can fill up the first molar too. And now you can do a crown on that, and you can put a composite directly on the second molar, and you've got the pulp protected in the second molar and the pulp treated in the first molar, all with the same material. And then you'd place the composite, cement the crown, and go back in and remove all the flash and adjust everything. So that is a new smile zirconium crown on the first molar. What cement to use? Well, you got to use TheraCal PT's brother or cousin, and TheraCal LC's cousin, which is TheraSem. It does release calcium and fluoride, and you go like, how can it do that? Well, again, you can do that. GC America did it with their MI Paste Plus. It is possible to do. There are ways to trick the calcium and not combining with the fluoride. And it has a very good shear bond strength too, which is excellent in light cure and self-cure mode. Never had a problem with TheraSem as a cement. It's been a very good cement. And, clinically, sometimes your zirconium crowns may appear kind of bulbous, but usually the tissue looks beautiful around them. I have a big, long lecture I give on zirconium crowns, and I tell you the tissue looks so much better than what you see around a stainless steel crown. And of course, radiographically, you can get those margins looking really, really good too with their zirconium crowns. And trauma, this is something where it's really important. Trauma is something where TheraCal LC really shines. And this is total pediatric dentistry, treating trauma. This is actually a hockey injury to this poor young man. He walked around with a broken front tooth for quite some time. He had a pulp forming on it. And of course, he had a complicated crown root fracture on the palatal. So I got anesthesia going, numbed him up really good, and removed the segment. And I said, hey, that's still restorable. So I excised the pulp polyp, and I want to get a rubber dam on, but I could not get a rubber dam on. Every time I tried to place it on the palatal, it would slide off, or if I put it up on the tissue, it would pull the tissue up onto the fracture. I wanted to be able to do a fracture repair. So I just said, okay, I've done everything I can, giving a lot of anesthetic in there to prevent bleeding. I'm going to go ahead and fix that all up. And then it got, hemostasis with my Vista 3% sodium hypochlorite with slight pressure. No bleeding has been prepped for a mirror Savec pulpotomy. Then I applied my TheraCal LC. Now it's bulky. I got a little glob there, and that's just something I had to live with. I didn't want it that bulky. You didn't want to get too thick. It's still just like over a millimeter thick at that point. But yeah, I couldn't do anything about it. I didn't want to move it because I didn't want to start any bleeding. I have no bleeding going on, which is very important. Cured it really well. So I cured it twice to get that cured. Then I fitted a strip crown form. And my favorite strip crown form for that is actually from Space Maintainer Labs. Adult strip crown forms. They're made in Venezuela, and they're very nice. Colombia. They're made in Colombia. And here's the fit. You see the nice tight fit, but there's no bleeding. I'm getting all the way down on top of the fracture. Poke my air vent holes. I poke it with a Sharp Explorer going from inside out, then etch. I did not etch directly next to the TheraCal LC. I kept a little distance away, best I could. Rinse off the etchant, place my bonding material, again, all bond universal. And had to make sure I carefully air dried it in between at the contacts, because before I light cured it, because I didn't want to cure those contacts shut. And then for aesthetics, I utilize the Sigma Estelite Quick. Estelite Sigma Quick is an excellent material for aesthetics and strength and polishability. Seeded that crown form with a composite, light cured it. And you want to light cure from the weak side first. So I light cured it from the palate first, then from the facial, then from the incisal. But you always want to cure on the weakest bond area first. That's the first one to cure. And then took off the crown form, did a little polishing there. You can see how nice it looks for aesthetics. A little bulky, which I had to do on the palatal for strength, but it was not an occlusion, so that was perfectly fine. Here it is, a post-operative check. Actually, this kid has had this for a number of years. Here's his post-operative check photo. Several years later, I published this in June 2017. I just saw him a few months ago. I took some new pictures, which I haven't had time to put in this presentation. So finishing up here real quick, here's my granddaughter Molly on her bike. What do I do if she had a trauma? Well, I really be worried about her. I love that little girl, Molly, so much, and she's going to be the world's most famous entomologist one day because she is really into bugs. She really loves her bugs. So when you do have bases, you need to have bases that are strong and durable. And one of the things about this is, as published in American Journal of Dentistry, written by John Burgess and all, is that you have significant decreases in compression with DiCal and VLC DiCal at just 24 hours and 90 days. So, compressive strength is very important. It's also very important that you have maintain an alkaline pH for those human dental pulp cells. You got to have a good alkaline pH. So I personally feel that you need to have a base material that contains calcium silicate, mimics the physical characteristics of tooth structure, so it's biomimetic, and it can stabilize and protect the dental hard tissues. And when you use a bulk fill, depth of cure is, of course, very essential, but you also need low Young's modulus. You don't want it too brittle. You want low shrinkage. Sure, you want it to cure, but you don't want to shrink a tongue either, because that can put a lot of polymerization stress at the margins. And you need to have it wear resistant and have some good aesthetics to a certain degree too. Now in pediatric dentistry, we don't have time to do 5 little steps. We want to be able to go in and get that done quickly. 2 steps would be okay. And you want to be able to go in there and bulk fill, because we deal with a lot of kids like this young man, could be a little tough. In pediatric dentistry, not every little kid is just an ideal little child. I think they all are perfect, myself, but they can come in like with a little bit of attitude at times. And depth of cure, this is Bisco research on their own product, their review comparing it to others, but everyone else showed too, they had a very excellent depth of cure. And you want to have depth of cure as security. Kind of like here is Molly holding her little baby sister, Natalie, and he knows how the pillow's there. And we're all watching very carefully, because everyone was, because you don't want little Natalie to fall, the little newborn. So last final case, and we'll be done. So here we have deep caries and a maxillary second premolar. And I would see these all the time in 13, 14-year-olds, kids coming with these massive big lesions. And, we can see how discolored it is. Actually, you get pre-wedging going. Pre-wedging is very important. On premolars, I use a 206 clamp. The rubber dam is placed to pre-wedge, which pre-separates. You clean the teeth first, you don't leave any plaque on it. And then you can cut your classic Ireland preparation named after Dr. Ralph Ireland with the rounded lying angles, because that really reduces stresses within the tooth for long-term strength of the preparation and the final restoration. So you have deep caries, it's soft in there, it's close to the pulp, but pre-wedge, so that protects the tissue. There's no bleeding. See, there's no bleeding. I'm not nicking the tissue. There's no bleeding at all. I can actually look down there and see the yellow at the base. So I know where I'm at. Now I can pull that out, put the matrix in, slide it back in. I'll have a nice tight contact. I've gone in and removed the rest of the caries. Again, this could be very sensitive in this young person, right? Later, if we don't do the right thing. So we go ahead, we etch the enamel for 30 seconds. Personally, I go in and I etch the dentin for 3 seconds, which removes the smear layer, but leaves all the dentin plugs in. If you've heard me before, I've shown you the SCMs and how 3 seconds removes the smear layer, leaves the dentin plugs in, which I think is an ideal way to practice. So this is using TheraCal LC. You place it in the deep portions just as a pulp capping. That's all we're doing. We're just going to remineralize any affected dentin, protect the pulp with calcium and alkalinity, which I already showed you will knock out strep mutans that would be in that preparation, in that in any infected dentin, but also somewhat in the affected dentin. Light cure for 20 seconds. Now you could use TheraBase, which is a marvelous product, or TheraCal PT, but I use in this case TheraCal LC, the light cure. You have to have a good light cure. Apply your universal adhesive like Albon Universal, but when you apply it, make sure you let it sit for a little bit, move it around. Beautiful research that everyone has forgotten about, but done not that many years ago, was that it takes time for your dentin adhesives, your universal adhesives, to actually penetrate the etched enamel and the dentin. If you rush it, you don't get anywhere near the length of the tags into the enamel. So then you light cure that. Now, when you light cure that, remember your adhesive is perfectly clear, it's transparent. You're giving a second light cure to the TheraCal LC. And this again is a pet peeve of mine, because when someone just goes ahead, they go ahead and they put on the TheraCal, then put Vitribon on top, you're preventing any further light from reaching the TheraCal LC. And the ideal situation is to have the TheraCal LC on the dentin, the deep caries, then the adhesive, the Albon Universal, which penetrates into the TheraCal LC. So when you light cure it, you have this extremely strong, highly resin concentrated outside layer of TheraCal LC, where the inside layer is still very hydrophilic and has a high concentration of tricalcium dicalcium silicate. Then you see it right there. So that top layer of the TheraCal LC is penetrated by the adhesive, creating the hybrid effect. Look at the hybrid effect. It really bothers me when people get it wrong. If I had covered that with a glass ionomer, I wouldn't have the hybrid effect, which is what you want. Now, I don't need a base because I'm putting in a bulk fill. And this bulk fill reveal replaces the dent. And so I put that in, I condense it down, pack it down in there, okay? So I got a nice tight contact, looking at a nice tight contact. I got it packed down. It looks a little translucent because it is a bulk fill. It would look a little gray, but that's okay. I'm hitting it with a light. And I'm going to peel back the sessional matrix and hit from the sides, cure buccal lingually. So you see on the matrices are peeled back a little bit so I can cure buccal lingually. And then I go back in, I place S-like Sigma Quick OA1. It's a superfilled material, small nanoparticle, fully cyanidized and spherical. I put that in, use my lateral condenser for anatomy, power cure that, peel back the matrix even more. I can peel it all the way back. Can't do that with a Toffelmeyer. You got to go peel it and peel. You have to buccal lingually light cure, make sure that's perfectly cured. Do my rough anatomy with a Raptor burr, polish it up. There's my rough anatomy. nice tight contact. There's the radiograph at 6 months. Here's a radiograph at 1 year. And it looks really good. Again, nice contours, good contact. The Theraca LC's in there. You've had the pulp shrink down, looking beautiful. I actually shot that off a computer screen, off the monitor, the picture of that. So here's some limitations. If you already have necrotic pulp tissue, if you have leaky restorations, if there's hemorrhage in there, if you leave behind a lot of infected dentin, using a light cure material in a do cure situation just never works. People, they put a non-bulk fill in, they try to put it in 4 millimeters deep, and they light cure, it doesn't cure all the way. And then if it leaks, the pulp dies, and that's like trying to raise the dead. You can't do that with any product out there. If it's already necrotic pulp, if it's already irreversible pulpitis, it's not going to be treatable with any type of biologic material. And finally, you have some good fluoride varnish. This is FluoraCal. It releases both calcium and fluoride, plus it contains xylitol. So you work on the microbiome itself too. You're getting rid of all the pathogens. You have better enamel fluoride uptake than the top brands, which don't contain the xylitol to work on the tissue health and getting rid of both the carcinogenic and the periodontal pathogens. And you also get calcium release. So you have the fluoride and calcium release, and you also have the xylitol release, which makes for a happy dentition. And so here's the family. It's my favorite picture, very old. It's actually the day that my oldest son gave the rights of Army officer, the oath of being an Army officer, to my middle son. And you can see my oldest son had already served in Korea and Afghanistan, and my middle son went to serve also. My oldest daughter is a psychologist with 2 kids, and my youngest daughter has a son, and she's a pediatric nurse. And middle son there, he's got 2 kids too. He has Natalie and Molly, and Keith is a brilliant mathematician, and that's a very old picture of him. He looks much older now. But you can always reach me, Mark Canning at northwestern.edu. There's Ryan in Korea. There's Ryan in Afghanistan at FOB Wolverine. There's Christopher at his wedding, officer's wedding. They get to cut the cake with his officer saber. Lots of fun. And that's when he got his wings as a pilot. And my oldest daughter, when she got married, and Christopher in Afghanistan, at a picture that no one's actually supposed to ever see, him with a number of top Afghan brass, provincial governor, and some other people are there. Anyway, so obviously the family has a lot of feelings about Afghanistan. So I would like to thank you extremely very much. Again, it's Mark Cannon, and we have our limit now. We're all finished. So if you have any questions, I'm willing to take any questions at this time, please. Oh, yes. On the 3-second etch, I would say that is something that it's one of my own things. So there's not anyone else, I think, recommending it, but we did some research on it and found that that really had the best result with removing just the smear layer and decontaminating. Well, I'm afraid I am out of time. So I'm going to let everyone go, and I really want to thank you very, very much.